Management of resistant hypertension. Imagine you're in the hypertension clinic. A 58-year-old man has been taking 3 antihypertensive drugs at maximum tolerated doses, including a diuretic, for the last 6 months. Yet today, his blood pressure is still 182 over 108 millimeters of mercury. Has his hypertension become untreatable? Should you simply add a fourth drug? Not so fast. Before prescribing another medicine, you need to ask a far more important question. Does this patient truly have resistant hypertension? The blood pressure machine may be wrong. The patient may not be taking the medications. Or he may have an underlying condition such as primary hyperaldosteronism or renal artery stenosis. In this video, we'll learn the stepwise approach to diagnosing and managing resistant hypertension, from confirming true resistance to choosing the most effective fourth-line drug. What is resistant hypertension? It is defined as blood pressure that remains above target despite treatment with 3-drug regimen. The patient is taking 3 distinct classes of blood pressure medications simultaneously. Optimal dosing. All 3 medications must be prescribed at their maximum or maximally tolerated daily doses. Includes a diuretic. Crucially, at least one of the 3 medications must be a diuretic to rule out fluid retention as the primary cause of resistance. Step 1. Confirm true resistance. Before escalating therapy or adding another antihypertensive drug, always rule out common causes of pseudo-resistance. First, assess poor adherence. Patients may not be taking their medications regularly because of side effects, cost, or simply forgetting doses. This is one of the commonest causes of uncontrolled blood pressure. Next, consider white coat hypertension, where blood pressure is elevated only in the clinical setting because of anxiety. Home blood pressure monitoring or 24-hour ambulatory blood pressure monitoring can help distinguish this from true resistant hypertension. Also, check for incorrect blood pressure measurement. An inappropriate cuff size, improper technique, or incorrect patient positioning can produce falsely elevated readings. Finally, review the patient's medications for interfering drugs. Common offenders include non-steroidal anti-inflammatory drugs, oral contraceptive pills, corticosteroids, and decongestants, all of which can increase blood pressure or reduce the effectiveness of antihypertensive therapy. Step 2. Optimize standard therapy. Before adding a fourth drug, make sure the patient is receiving the most effective 3-drug regimen at optimal doses. The recommended core triple regimen consists of an ACE inhibitor or ARB, a calcium channel blocker, and a diuretic. Many patients achieve blood pressure control simply by optimizing this combination. Next comes diuretic optimization. If the patient is taking hydrochlorothiazide, consider switching to a more potent and longer-acting thiazide-like diuretic, such as chlorthalidone or indapamide, which generally provide better 24-hour blood pressure control. In patients with chronic kidney disease and an eGFR below 30 milliliters per minute per 1.73 square meters, traditional thiazide diuretics become less effective. In such cases, loop diuretics such as furosemide or torsemide are preferred. Step 3. Look for secondary causes. One important cause is chronic kidney disease, where impaired renal function contributes to persistent hypertension. Another common and potentially curable cause is primary hyperaldosteronism, characterized by excessive aldosterone production leading to sodium retention, potassium loss, and resistant hypertension. Also consider renal artery stenosis, which activates the renin-angiotensin system because of reduced renal blood flow. Obstructive sleep apnea is another frequently overlooked cause, particularly in obese patients with loud snoring and excessive daytime sleepiness. Finally, although uncommon, pheochromocytoma should be suspected in patients with episodic headaches, palpitations, sweating, and markedly elevated blood pressure. Step 4. Add-on drug of choice, spironolactone. Why is spironolactone so effective? In many patients with resistant hypertension, excess aldosterone plays an important role by promoting sodium and water retention. As a mineralocorticoid receptor antagonist, spironolactone blocks the action of aldosterone, producing a substantial additional reduction in blood pressure. This is why it is particularly useful when primary hyperaldosteronism is suspected, even before the diagnosis is definitively confirmed. However, spironolactone must be used with caution. It can increase serum potassium, leading to hyperkalemia, especially in patients with chronic kidney disease or those already taking ACE inhibitors or ARBs. Therefore, potassium levels and renal function should be monitored regularly after starting therapy and during follow-up. Step 5. Further add-on options. If blood pressure remains uncontrolled even after adding spironolactone, additional antihypertensive agents may be required. A beta blocker is a good option, particularly in patients with ischemic heart disease, where it provides the added benefit of reducing heart rate, myocardial oxygen demand, and cardiovascular events. An alpha-1 blocker, such as prazosin, may be considered, especially in patients who also have benign prostatic hyperplasia, because it lowers blood pressure while improving urinary symptoms. Another option is central acting agents such as clonidine, which reduce sympathetic outflow from the central nervous system and thereby lower blood pressure. However, they should be used cautiously because of adverse effects such as sedation, dry mouth, and the risk of rebound hypertension if stopped abruptly. Finally, vasodilators, including hydralazine and minoxidil, can be used in refractory cases. These are potent antihypertensive drugs, but are usually reserved for later stages because they may cause reflex tachycardia and fluid retention, often requiring combination therapy with a beta blocker and a diuretic. The stepwise approach at a glance. Let's conclude with the stepwise approach to resistant hypertension. Step 1 is to confirm true resistance by excluding pseudo-resistance due to poor adherence, white coat hypertension, incorrect blood pressure measurement, or interfering medications. Step 2 is to optimize triple therapy by ensuring the patient is receiving an ACE inhibitor or ARB, a calcium channel blocker, and an appropriate diuretic at optimal doses. Step 3 is to exclude secondary causes such as chronic kidney disease, primary hyperaldosteronism, renal artery stenosis, obstructive sleep apnea, and pheochromocytoma. If blood pressure remains uncontrolled, step 4 is to add spironolactone, the preferred fourth-line agent, while monitoring potassium levels and renal function. Finally, step 5 is to consider further add-on agents such as beta blockers, alpha-1 blockers, central acting drugs, or vasodilators based on the patient's comorbidities and clinical profile.